a pleasure to invite Dr. Mass to present to us on pharmaceutical costs and prices. Dr. Mass, the floor is yours.
Hi, thank you so much for having me. I really appreciate being here from across the country. I'm here in suburban Philadelphia. I work for Children's Hospital of Philadelphia. I don't speak for them when I advocate. We're a big tent here at CHOP. I'm a graduate of Duke University Medical School, and I trained in pediatrics at Northwestern. And I have to say, I really enjoyed Dr. Jackson's talk. It's, asthma is a huge issue, and I'm actively practicing today. If you saw me stand up, you could see my scrubs on because I ran home and pulled the jacket on and didn't get a chance to change out of the scrubs. But I had a shift today, and I see every shift I see kids with asthma. So it's very important. I'm going to try to share my screen. There's something, I think it was a teenager in my house that did something to the computer. So I'm having Wi-Fi issues coming on and off. If I get blocked off, I'll come on my phone, and I can do this on my phone. And it's not a problem, but I guess I'll do share screen, and I'll go to my PowerPoint. And yes, so insulin prices and the Affordable Insulin Now Act. You can all see this, yes? Wonderful. And the audio is okay? All right, and then I guess people will be listening by audio, so when I get to the slides that are visual, I'll try to visually describe them, and we'll make it richer, I suppose. But we're all used to Zoom now, aren't we? All right. So some things about diabetes in general. Hold on. We need to go to, let's do slideshow. I think that'll be better. Play from start. Okay. All right. So some statistics about diabetes, just in general, and just so that you have some numbers. I mean, we always hear science is about numbers. It was a famous Lord Kelvin quote. You can't have science without numbers. They got to have some numbers. So this is from 2019, the American Diabetes Association statistics. Over 37 million Americans, 11.3% of the population had diabetes in 2019. It's a big deal. The numbers are actually increasing, and we're expecting increases. 29.2% of Americans age 65 and older. So for our Medicare patients, it's a very, very big deal, nearly a third. If we look at the different types of diabetes, type 1, of course, being the kind that you need insulin. You need it to live. There's 1.9 million Americans like that. It's a life-sustaining drug for them because their body doesn't, the islet cells in their pancreas just don't make the insulin. They have to get it extraneously. And we're going to talk about that medication and its cost in a few moments. And of that 1.9 million, 244,000 are children and adolescents that have type 1 diabetes and thus require insulin. I bet every one of you can name a child in your life or a friend in your life that had diabetes when they were young. And I've diagnosed multiple children myself. So it's a big concern. Let me see, next slide. All right. So when we look, there are some deeper statistics about diabetes. There is a disproportionate amount of minorities that are affected. 14.5% of American Indians and Alaskan Natives have diabetes. Of non-Hispanic Blacks, 12.1% are affected. The number is 11.8% for our Hispanic population, 9.5% for Asian Americans, and 7.4% of non-Hispanic whites. So if you look at all minorities, they're disproportionately represented. We're looking at a disease that affects minorities more than it affects our non-minority population. The cost of diabetes. First of all, the cost in life and pain. I'm giving you the death certificates. Sorry, I don't know how that happened. So in 2019, diabetes was the 7th leading cause of death in the United States. 7th. That's pretty big. I mean, I think maybe it would be 8th in 2020 because, COVID came along, but there were over 87,000 death certificates where diabetes was listed as the underlying cause of death. It's a big deal. And, if you think about the pain and suffering that you go through, I think of those children, when you're a small child and all of a sudden you have to sometimes, frequently prick your finger and check your blood sugar if you don't have the diabetes pump yet at that point. it's painful. It's painful to do that all the time. There's a lot of cost to diabetes in terms of pain and suffering. And then if we actually look at the cost, it gets very expensive monetarily wise. And even though that should not be our main concern, we have to address it because of the cost of medication that we're going to talk about in a moment. 327 billion, the total cost of diagnosed diabetes in the United States in 2017. That's the year that we have the most updated statistics for. 327 billion with a B. We all got the B, right? And of that, 237 billion was for direct medical costs, hospitalizations, medications, etc. So on the last day of March in 2022, the news came out that the Affordable Insulin Now Act passed. And since 2018, I've been following drug costs of all sorts and who's causing our high drug costs. I mean, you'd have to be really under a rock to not figure out that our pharmaceutical prices are out of control. I mean, raise your hand if you've heard that drug costs are high in America. Yes? Yes? Anyone? Bueller? Okay, yes, okay. They're high. We know this, right? Thank you. I see you're smiling. I have to keep you awake. That was the later presentation. But so here this act passes and we see headlines everywhere. And we're going to talk about this act in a couple of minutes after we dissect why insulin is so pricey. But Representative Lloyd Doggett, who voted for this act, actually said on the floor of the House of Representatives that the Affordable Insulin Now Act, quote, does not lower the price of insulin by 1 penny. Wait, isn't this what we were trying to do, was lower the price of insulin? Well, let's take a look at this price of insulin. These are two images here, and for people who are listening and only getting the audio, what we have here is the cost of insulin over time for two different particular companies that make the major insulin that we use in the United States. The graph that we're looking at on the left side of the screen is for Sanofi's product Lantus. And we start in 2012, and you can see the graph tracing out over time that what we call the list price for insulin has gone up by 140%. And the list price for a single vial of insulin, that's what this graph shows, is currently running right now at about $350, $360. That vial, by the way, it costs about $10 to manufacture. The list price is $360. It costs $10 to manufacture. Is something wrong here? Something is very wrong here. My screen may have frozen, so I'm like closing my eyes, but I'm not really closing my eyes, but that's okay. We'll just continue the talking. However, the net price is going down. What is net price? What is list price? And we see the same thing if we look over here for Humalog. We see that the Humalog is, once again, it costs about $10 to manufacture. What we're calling the net price is flat, has gone down slightly, but the list price has gone up, maybe not quite as high as for Sanofi, but this Eli Lilly product of Humalog is also going up, and it's the list price that's high. Well, let me explain the difference for you between net price and list price. This net price that over here on the left side of the screen, that Sanofi, for the Sanofi drug, essentially what the net price is it's what the pharmaceutical company collects. So the pharmaceutical company is collecting about $50 for a drug that costs about $10 to manufacture. So they're getting too much, okay? No argument from me there. However, the list price, this list price is what the pharmaceutical company collects, plus what is commonly referred to as rebates with also some fees thrown in. Well, who's collecting the rebates and fees? Because if you look at this graph, roughly 80% of the cost of insulin is going to the list price, which is coming from rebates and fees. It's the difference between the two lines in the graph. The rebates and the fees, they're collected by, well, not my friends, but sort of someone who's been in my target now since 2018, the PBMs, the Pharmaceutical Benefit Managers. And the same thing is happening over here with the Eli Lilly product, Humalog. Eli Lilly is collecting around about $60 for a vial that should cost about $10. They're collecting more than they should be. However, the list price, the difference what's going to the PBMs is much more. So if we look at the rise in cost of insulin going up 140%, the major reason for the rise of the cost of insulin, is it the pharmaceutical companies or is it the PBMs? You can say it, someone can say it. It's the PBMs.
PBMs.
Yes, thank you, exactly, PBMs. Say it over and over again, start putting it in hashtags. Well, what is a PBM? A pharmacy benefit manager. Some clever people who are doing investigations on them in the state of Ohio call them pirates bilking millions, like, so you can come up with all kinds of clever little things that you can say. A PBM, they are large companies that process and administrate prescription drugs. They also make the formularies. In case you're not familiar, the formulary is the list of what is covered by insurance and other third parties like Medicare and Medicaid. So if formularies have different tiers on their list, so things are covered by higher and lower levels. These PBMs do not manufacture and they don't research. So you don't want to think about people wearing lab coats and, in labs and, doing the work, or you don't want to think about people that are on the lines manufacturing. You want to think about suits. They're writing the contracts. How interesting. One of the things that I found out in medicine that made me drop my jaw, I just couldn't believe it. These PBMs, these people who are making these lists, these formularies, they are allowed to collect kickbacks legally. These rebates are actually kickbacks. How do we know? Because the PBMs have an exemption from the anti-kickback statute. They use the word rebate, but I can assure you that that money is not flowing to the patient. And I can also tell you that these kickbacks, and let's dispense of the word rebate because it's not a rebate, that these kickbacks are not at all transparent unless a pharmaceutical company comes along, like they did in these two cases, and tells us, or unless the PBM would voluntarily say, hey, we're getting this much in the kickback. I also want to point out to you, if you look on the right side of the screen, Eli Lilly has a generic product of Humalog. It's called Lispro, and they put it on the formulary here. And Lispro, even though it is $137 cheaper than the $275 for the branded product, Lispro doesn't make the formulary. In other words, the PBMs are not choosing it for the formulary. And if you look at the graph, you can see why. Because the PBMs are going to make more money off a more expensive drug. They're perversely incentivized to pick a more expensive drug. And by the way, do you think this is happening for just insulin or for nearly every drug in America? I can see Ms. Moreno sitting there nodding her head, and I can see what she's saying. It's nearly every drug in America. This is actually quite shocking. In some conservative studies, we think that the PBMs are collecting 200 to 300 billion per year. They have more revenue streams than just the kickbacks and the fees that they collect, and we won't get into that. If you want to look me up, you can look up America's pharmaceutical middlemen and legal thievery. I've detailed all of their little revenue streams. I've been following these suits for quite a while. I have a lot to say about them. They don't like me very much. So 3 PBMs. It's once again with healthcare, look for the hidden moneymaker, look for the hidden profiteer, the hidden corporation, and also look to see if the business model is corrupted by consolidation, and it is. There are 3 PBMs that control 77% of all prescriptions in America, and I bet you've heard of at least one, if not all 3 of these companies: Optum, CVS Caremark, and Express Scripts. And how interesting, over the last several years, you can pay attention to column 1 here with Pharmacy Benefit Manager and column 3 with Insurance Company. These insurance companies, they all have their own little personal PBMs, or the PBM has bought the insurance company. Old CVS here in 2018, and I wrote an article on this in the Hill publication, CVS had 62 billion lying around, so they bought Aetna. Who buys an insurance company? And by the way, how do you get so much money to buy an insurance company? If you're CVS Health, you think it's because of all those cute little stores with a fancy little heart on the corners, but it's not. 60% of CVS's revenues come from its PBM. Express Scripts here, they got bought by Cigna. And when Cigna, the insurance company, bought Express Scripts, their revenues tripled. that tells you what you need to know, that these PBMs are the cash cows for the insurance companies. So America complains about its insurance companies, and they are a problem. But now they're consolidated to the pharmacy benefit manager, and the pharmacy benefit manager is highly consolidated. And you can look at this list of insurance companies, and you all know they're highly consolidated too. Everyone's consolidated. It's like they're all up in everyone's business. And then they're running their minute clinics, and they're busy actually buying physician practices, and they have specialty pharmacy for mail out drugs. All kinds of other shenanigans are going on. You have to read real deep. But I want to get back to the Affordable Insulin Now bill. Remember when I told you that Representative Lloyd Doggett, a Democrat from Texas, told us on the House floor, it does not lower the cost of insulin by 1 penny. What does it do? It lowers the copay for Medicare and the commercially insured. That means what you pay out of pocket, and only for Medicare and only for the commercially insured. The uninsured, and there's, I think, I believe over 17,000 of them that have insulin dependent diabetes in America. And that number is going to rise because of the poor health that these, patients suffer under. The uninsured, they're out of luck. They are going to pay that full inflated cost of insulin, that 360. The insurance, the people without insurance at all, the ones that need it the most, they're going to pay the full inflated cost, because the Affordable Insulin Now Act doesn't do a darn thing about the list price. It doesn't lower the cost of insulin. It only lowers the copay. Now let's go back and think what happens. So 60% of Americans receive their insurance through their self-funded employer. So now it's the employer in this case that's going to pay the full inflated cost. Are those employers going to want to pay the full inflated cost? You can shake your head yes or no. No, they're not going to want to. So they're going to pass more of that inflated cost on in higher premiums for their employees. They're going to probably have them pay in other methods. They're probably going to lay off people if they have to keep on paying the 80% cost that's going to the PBMs, and it's inflated way above what it should be. That vial should be costing $10. And by the way, sometimes diabetics go through, 5-6 vials a month. Dr. Mandel, I'm sure you have seen in your practice patients that go through 5-6 vials a month. So now go back to the picture, and you realize that they're paying 350 times 6. This is a real problem here for these patients that depend on this medication for their life. So the employer is going to pay the full inflated cost, or they're going to pay the kickback. But the kickback is still getting paid. The PBM is still getting rich. The insurance company is still getting rich. You're all paying more, and you're all getting less. So if you look at Medicare, the Medicare money is going to pay that full inflated cost as well. And that means that functionally your taxes are paying the kickbacks. We're paying for kickbacks. Your taxes are paying for kickbacks. Your employers are paying for kickbacks. Your grandkids are paying for kickbacks. Is there anyone in this room that can tell me why a large company that owns insurance companies and all kinds of other integrated networks, why they deserve the special right to receive legalized kickbacks? Does anyone have a good reason? And please raise your hand, interrupt me, have something to say. I mean, I've been in the halls of Congress, multiple times. I mean, more of us need to call them and tell them that we know about the kickbacks. It's absolutely absurd. And then, once again, back to following the money. We're all going to continue to pay this. And by the way, look at the trajectory. It's going up. And it's not just doing this for insulin, it's doing it for other medications too. They're perversely incentivized to pick the more expensive drug. The rheumatologist friends that I have tell me they're picking the most expensive drug for the rheumatology, issues. They're not picking the drug that works. They're picking the best drug money buys them so that they can keep it all going, flush and cash. Terrible, disgusting, reprehensible. We really need to be doing something. I don't want to make this too long. I will take time for questions. But there is hope. This bill passed and the Senate got to work on it right away. And why? Because I have a lot of emails now. I've been trotting around Congress since 2018 or before 2015. I don't know. I got really active like in 2018. Maybe they like it when they see me coming, but I doubt it. So So I got busy and I started emailing the Senate because the Senate's got to do something, right? And not that I know these people in particular, but I certainly know people who can get to these people. Senator Collins, a Republican from Maine, Senator Shaheen, a Democrat from New Hampshire, both senators, and then Representatives DeGette and Reed, who are representatives from the Democrat and Republican Party. So this is nice. It's like people playing across the aisle, like we all should be, of course, right? So they are the Diabetes Caucus co-chairs for the Senate and the House. And they are looking at priorities and they were asking for input. Certainly some of the organizations I've worked towards have given them input. And they're looking to lower the insulin costs, and they were inviting lawmakers and other stakeholders to share input on the final legislation. So a part of their policy priorities were ensuring that PBMs cannot collect these rebates. We're putting waivers on deductibles and limiting copays so that the copays were still low, supporting patient access to make sure that prior authorization and other medical management requirements can't be imposed to limit the use of insulin. Just as a little aside here, like for these medications, remember how they make the formularies? If your drug is not on the formulary, even if you're like written for a particular drug, I don't control what you get, what gets covered. It's the PBMs that control it. The suits are controlling it, not the scrubs. The people who were trained to tell you what medication you need to keep your life rolling or to keep you healthy, we don't have the control. These old, PBMs over here that are integrated in with the insurance companies, they're the guys that have the control. All of these pharmacy benefit managers here, not us, and they have it for every other drug. So when they make us do a prior auth, what they're making us do is play like a game of like Mother May I. So the patient gets written the prescription and they come along and they say, no, you can't have this. You have to do a prior auth, and they make you jump through hoops. Physicians, incidentally, are doing like 17 hours a week average doing prior auths. It's another big issue. There's a bipartisan bill on that, but it's a horse of another color. So I think it's absolutely wonderful that people are getting together across the aisle. It's because they know they have to get it done. And frankly, it shouldn't just be in Pennsylvania. It shouldn't just be California. You should be telling all your friends, you need to call your lawmakers and tell them to do something about the PBMs, expose their costs, get rid of their legalized kickbacks. I can think of like fewer people that I'd want to receive kickbacks than the PBMs. They're some of the most untrustworthy companies I've ever read about. So am I riled up and passionate about it? Yeah, I am. Because, I'm tired of patients telling me they can't get their EpiPen, they're too expensive. Their doctor tells them if they don't get the EpiPen, just try to avoid bees. I'm like, really? Avoid bees? Excuse me. Like, we're talking about children here. We're talking about seniors. We're talking about 1.9 million Americans that need and deserve access that's affordable to a drug that should cost $10 a vial, and it's over $350. This is criminal. So I've left a big blank box here, a big black box, just like the big black box of the PBMs, because we can't really see all their money as clearly as we want to. And I'll take some questions.